Well, first of all, I would like to thank you for saying yes to our interview. Nice to meet you. Personally, it's my honor to interview Dr. Andrew Moore from Oxford Pain Relief Unit. Can you introduce your unit and your people and team at Oxford?
Sure. We've been working together as a group on pain really back 35 or 40 years, an awfully long time. And it was because there was a chap in Oxford called John Lloyd, who was the person who started pain units in England. And he really knew he had to do something. But he'd say, these people are suffering, I don't know what to do, but we've got to do something. And so we began to meet and we began to do things like clinical trials. And at that time I was a practicing biochemist and I ran the biochemistry labs, and we were doing pharmacokinetics of opioids and other drugs, clinical trials and so on. And then, we were very anesthetically based. And then come about 1994, I was in Florida, and I listened to a guy called Abe Sunshine talking about clinical trials of aspirin. And he was talking about why some of them worked and why some of them didn't work. And I sat at the back of this really large auditorium and I thought, this is a really important point. We've got to understand this. So what we tried to do then was to move, this is about the end of the 80s, very early 90s, was to start moving towards trying to understand more about what clinical trials do and how they work, rather than just carry on doing clinical trials without thinking. So we collected together about 25,000 randomized controlled trials with pain as an outcome. And the idea was that we needed to start doing systematic reviews about them. This is before evidence-based medicine was evidence-based medicine. And basically, it took off from there. We did at various stages have people who are very famous now come through and work with us. Sometimes we had a larger group and sometimes a smaller group. But when we started looking at doing systematic reviews, we found the methods didn't work for us. And there were things going on that we thought were wrong. So there were all of these stages where we had to say, this is wrong, how do we make it right? How do we make this better? And it's moved. It's taken us, over 20 years to get to a stage where we're beginning to feel that we're comfortable. And our group these days is quite small in Oxford, because we've got the PAPAS group with Chris Eccleston and Anna Hobson who runs it. There may be more people there soon. There's myself, there's Phil Whiffin, who used to be the Deputy Director of the UK Cochrane Centre. He's a pharmacist and has been working with us for ages. And there's a superb woman called Sheena Derry, who is a zoologist by training, but she is also a clinical pharmacologist as well now. And she's just the bee's knees. I don't know whether that translates into Korean, but it just means that she is absolutely wonderful at doing systematic reviews. So we've got this team there, that we get people coming through and training, and maybe doing one or two reviews, and sometimes more, and sometimes they just keep coming back. So they're with our group in the UK, and then we have tons of people around the world who are associates in Germany, in Canada, in Switzerland, none in Korea yet.
Oh no!
But we
it's
must.
A shame.
I've been to Southeast Asia a few times, not to Korea, to try and tell people about evidence-based medicine and what we can do with it, and hopefully to try and get people involved. But it's proving quite a hard work.
Right.
Anyway, that's where we are. So now we're a sort of an international virtual association of people who are interested in making things better.
Okay. You've been funded by various pharmaceutical companies for
Yes.
your research. How do you keep yourself clean?
Well, it's a very simple thing. There's an old saying that when you sup with the devil, you use a long spoon.
Oh.
Now, we've been working with the pharmaceutical industry for decades.
Yeah.
We had a very simple rule when we started, and that is, if we did research, whether it's a clinical trial or something else, we had the absolute right to publish the results.
Right.
And when you have that rule, some people won't work with you because they want the absolute right to publish the results or not. We won't work with people like that. So if you're a pharmaceutical company, you want to work with us, that's lovely. But at the end of the day, the results are going to be published, whether you like it or not. All right? And that perhaps explains why so few pharmaceutical companies work with us. But the reasons why we do it are really important. Because if you're looking at clinical trials, you can look at a published paper, but that's done to a formula. And what if the formula's wrong? If the formula's wrong, there's no way you can unpick it because you don't have the data. So you need access to the data in the clinical trial at the level of the individual patient. And the only trials that are done these days are done by pharmaceutical companies. So you've got to cozy up to them and make them understand why allowing us to have their data and to reanalyze it in ways they may not like is good for them. Be quite good at that over the years, and we've managed to get rather large amounts of data, including data that would have otherwise remained unpublished. And it's been important because looking at that has allowed us to concentrate on some really important issues, like issues around trial design. What happens when people drop out of trials? Now, typically in trials, people use the last observation carried forward method. I mean, it's fine if 2% of people drop out of trials and make any difference. What do you do? But if 60% of people drop out of trials, which happens, for instance, with opioids in chronic musculoskeletal pain, it means that if you don't take it out and you just use this LOCF method, then what you have is a result which is based on hypothetical data. So we have gone back and looked at it, and what we find is that using other methods where you define an outcome as one that patients want, so that's more than 50% pain intensity reduction, and also they have at the end of the trial to continue to be still taking the medicine, then that you get completely different results. And sometimes trials which said this drug is wonderful actually show that this drug is significantly worse than placebo. So that's a big effect. And similarly, we've been able to look at different outcomes to see which is best, which is more sensitive, whether the ones that patients want are measurable, and importantly, really importantly, the relationship between improvement in pain and improvement, for instance, in chronic pain, in terms of the sleep deprivation that people get, the impairment of sleep, in the depression, the fatigue, quality of life levels which have gone down, and also in the ability to work. And the answer is that we've been able to demonstrate whenever we've done it, is that when you improve the pain, all these other things come back to normal. It's most impressive. So what we've been able to demonstrate is that, it's the pain is the thing, and this works. So and we've done that because we've had individual patient level data from pharmaceutical companies, usually for which they have paid, but we have had an absolute right to publish. So on that basis, it's all transparent. You all know what's happened. The data are there. You can look at it and say, well, have I done it wrong? Nobody's come along yet and said we're doing it wrong. And frankly, they never will, because I don't think we're doing it wrong in ways that we can see. But we carry on looking for things that might have made us come to the wrong conclusion. What we're looking for is the truth.
Do you think other pain research units have the same rule as yours?
It is very difficult. Without wanting to, be a bad boy, I think that there is a lot of nonsense talked about industry, but at the same time, there are people who do clinical trials with industry where they're not being published, although that's almost impossible now because we've changed the ground rules. But I'm not convinced that everything is completely clean. But you can only look after the bit of world that you look after. I can't change the rule of the world.
Okay. We we understand that you majored in biochemistry.
Yes.
Yeah. How did you come to work in this field, evidence-based medicine and pain research?
Well, I did. I actually went up to Oxford to read medicine and then changed because it was more interesting to read biochemistry. And the professor of biochemistry at that particular time was Professor Hans Krebs of the Krebs cycle. It was a very exciting time. And then I did a DPhil, which is a PhD, in the hospital, which had a joint university hospital biochemistry department. And while I was there, I was asked to involve myself in analytical biochemistry, because I was a whiz at measuring things. And so I got involved with inborn errors of metabolism and diagnosis. And then I was asked to stay on and be a biochemist. But my
because
job...
you're an excellent student?
Maybe, I don't know. Maybe because I'm awkward. And basically what they wanted me to do was to go out onto the wards and find ways in which biochemistry could help medicine. So I had 13 years, absolute wonderful time. I had the only laboratory in Oxford. And so anybody who wanted to do research had to come to me. So eniology, we did fabulous stuff. It was very exciting. And as part of that, I got involved with the Department of Anesthetics in terms of measuring opioids, fentanyl in the first instance, buprenorphine later, and then morphine and its glucuronides. We developed big interest in pain and anesthetics. And although I went and then did some other things, including starting a diagnostics company and running it up to a moderate size in a short time, my interest was always in analysis, and particularly how you get the right result. Mm-hmm. That's a really important thing. And so back in 1990 or thereabouts, as we were still putting all this stuff together about pain and how we looked at it, it just became evident that this was going to be a big thing, and I just decided that I would support myself but get involved in this, which is what I did. And then I ended up writing an evidence-based newsletter, Bandolier, and then it went on the web and it became very successful at one stage with millions of people going in there every month.
Right. I myself had a great help from your site.
Well, thank you very much. I mean, we've stopped now because, we're tiny. And we were doing it ourselves. We could never get funding for it.
It's a pity.
It is a pity. It was a pity. But we're trying to do things now. We're beginning to investigate whether we do something with Wikipedia. Might be helpful. With all of this work we did, pardon me, and Cochrane, and so on, it's just more than enough work to be carrying on with. So, and it's very important, and I like it. It's enormous fun.
Could you tell me briefly about your presentation, yesterday's presentation?
Absolutely. It is one of these things that came from a conversation with a pharmaceutical company about aspects of interest and how and whether individual patient data analysis could look at it. So we were having this conversation with Reckitt Benckiser, it was. We'd done some work with them before. And they were saying they wanted to try and show how could they show what was going on, individual patient data analysis. So we had the data, and I think you saw some of the pictures there. We were able to demonstrate beautifully what was going on. We went away and did some additional analyses looking at the pharmacokinetics of oral analgesics, particularly oral ibuprofen, where there was a lot of data. And what one sees is that with standard acid ibuprofen, it has a peak plasma concentration of about 90 or 120 minutes. If you use one of the fast-acting ones, which is an ibuprofen salt or a liquid gel capsule, it's about 20 to 30 minutes. And we had noted that a 30-year-old paper had indicated that there was a relationship between pain and early plasma concentration levels. So we did a big analysis, and what we showed was that the faster the pain goes down over the first hour, the better the overall pain relief and the longer the pain relief lasts.
Uh-huh.
So it wasn't just that going in faster, it came off faster. Going in faster really was determining the way in which this worked, possibly because of some kinetic event that you're driving the drug into the place where it works and therefore getting better effect. And then we were able to take another trial and do the same again and got exactly the same results. And it's very interesting, so that, for example, 200 milligrams of fast-acting ibuprofen gives you the same analgesic response as 400 milligrams of ibuprofen acid, the standard formulation, which is good stuff. And if you're able to get at least the same, if not a little bit better analgesia, a half a dose, well, of course, that's a really major safety consideration for what is an over-the-counter medicine used by millions of people.
Can you tell me the analgesic with a faster onset keeps the analgesic effect longer?
Yes.
But to when?
Well, I don't know that we've got enough data on that yet, but for example, ibuprofen normally would last about 4 to 6 hours.
4 to 6 hours.
But for the fast-acting drug, what we're seeing is that half the people had not remedicated, needed another analgesic.
So no pain at all?
By and large, they weren't needing any pain relief till beyond 8 hours.
You enjoy your work very much.
Absolutely.
Yeah.